Welcome to the SPRT Therapy Podcast, where top doctors, trainers, and athletes share their secrets to moving better, recovering better, and performing better.
I'm going to tell you right now, if it wasn't for Tim Brown, I would have never walked again or surfed.
Come a little bit closer, hear what I have to say.
Please join hosts Dr. Tim Brown and Dr. John Pecora for today's conversation.
Thanks so much for joining us today. I'm Dr. John Pecora.
I'm Dr. Tim Brown.
And I'm Dr. Jason Amstutz.
You are,
Yeah.
and thanks for joining us. We're gonna get into your background a little bit, Dr. Jason Amstutz, who's a good friend of ours, and for sure one of the smartest guys that we know, and will be presenting at this year's SPRT Therapy Sports Movement Symposium. And so we wanted to have you on to kind of, share, not only your insights, what you've learned over your long career, blow some people's minds, I think, relative to what we think that we know about fascia and fluid movement, and just the human body in general. But we met 20 years ago, I think, maybe even longer, at CCSP lower body, I think, hip course that Brendan Murray was teaching.
That's right.
The cuboid adjustment that you showed me that day, I still use on a daily basis to this day. But then you went off after that. You were traveling and working with some professional athletes, and then you disappeared to Montreal for about 4 years, maybe even longer, to pursue osteopathy and work with Guy Voyer. Then you disappeared for another 5 years. We thought, you had a bunch of NHL teams and some other teams that were flying you around. We thought that you were just on tour with a bunch of teams. Come to find out, and I think the NDA is up, and we can get into that later, that you were traveling with one of the world's most recognizable athletes for about 5 years. Came back, started teaching some courses, and there was a moment for me, and this was maybe probably 10 years ago or even longer, when I sat in. You were gracious enough to invite me to one of your courses, and I would sit in the back and try not to disrupt anyone, but get up, maybe an hour to 2 hours in, and my brain would just be so melted from what you guys were talking about, that I'd have to leave just to try to absorb what it is that I just witnessed or listened to. And you were going into some of the anatomy, and you were mentioning ligaments and tendons and structures that I had never heard of. Now, I wasn't, top of my class in anatomy and physiology. I don't think I wasn't valedictorian, but there was so much stuff that I had never even heard of.
Neither was I, John.
And I grabbed you after, and I said, like, what language were you talking? Like, what are all these structures? And you went into the fact that, European anatomy books are so different from ours, because of the preservation process, formaldehyde and everything. It would burn away a lot of the fascia, a lot of the structures that in European anatomy textbooks, were pretty common knowledge. And, that was pretty interesting for me, but, and I know that Tim has a bunch of questions for you as well. But, wondering if maybe you could just kind of go back to the beginning as far as, your story, your history, kind of what got your classically trained sports chiropractor, but then, went down, a completely different path, or not a completely different path, but continued to learn and evolve, your education. And so just wondering if maybe, you kind of talk about what maybe got you into school in the first place, and then how that kind of evolved and where that went. I mean, I know we probably only have about 4 hours today, but if you could kind of share that.
Sure. That's okay. I was injured as an athlete. I broke my fibula in 2022 in May, playing Australian rules football. And I was part of the U.S. team at the time, and I had been playing for the U.S. team since 1998. So that's like I was started at 26, and then, 3 years later, we were headed down to Australia for the first ever international cup. So it was like this really big deal to go down and play Aussie rules in Australia, mind you, in an international tournament where the team that came, or the country that came up with the sport, was not allowed to participate because they would have kicked everybody's what. So I broke my leg in early May. This tournament started at the beginning of August, and believe it or not, I did my rehab in Rancho Santa Margarita Pro Sports with Joe Donahue. Joe Donahue. So I was right.
Legend.
So anyway, right, total legend. So I go through this process, and I also met another guy there who was helping out. Anyway, I go through this process, and I make it to like middle of July, right? I got 3 weeks to prep. I go out and I try to do my on-field stuff, and I was able to go straight as fast as I used to be able to, and potentially slow down. I couldn't go lateral. I literally couldn't go to the side. I now know that I didn't have any eversion, inversion, talar movement, all these other things. So anyway, I was in dire straits, and I ended up at a chiropractor's office. I got adjusted on my ankle a couple of times, and it totally freed up the movement, and I was able to participate and go spend a month in Australia. And that's when I was like, up until then, I wanted to be a surgeon. That's kind of what I always grew up thinking that I wanted to do. And then I was like, you know what? I remember sitting in my car one day after I had retaken my MCATs, because the first time they expired, which is not, I don't ever recommend doing that. Why would you do that to yourself? That's procrastination at its finest. So anyway,
or maybe it was divine intervention. Maybe it was divine
intervention. I literally was sitting in a parking lot in my car, and I was trying to wrap my head around becoming a chiropractor and not being a surgeon for many reasons. One of which was, it seemed like maybe there wasn't the respect that you could get as a surgeon. That was important to my ego at the time. And then I just decided through a series of things that if I'm going to do it, I'm going to be the best that I can possibly be. So that kind of set the tone for me. I quickly enrolled in school, and I think I started at LACC 6 months later. Met Dr. Scaringe and the whole bit and everybody there. So all of which are still like a part of my life, and obviously part of what has created who I am today. Then I did chiropractic school. I studied all the things that we all do. And when I graduated, I wanted to be a sports chiropractor. At the time, that meant to me ART, Trigenics at the time, which I had been introduced to Trigenics even before ART, I believe, through one of my interning docs in Florida, Dr. Richard Shake.
Is that the BioTensegrity group?
No. This is Dr. Austin Olo. Have you met this guy out of Toronto, Tim?
Yes, I have. Yeah.
Applied neurophysiology using acupuncture meridian points and other things, and manipulation of the nervous system and the fascial system through the Golgi tendon apparatus and the muscle spindles. That was his whole thing. And It was like really, and it still is. I use it still. It's really incredible stuff. Anyway, that's kind of what formulated my early chiropractic stage career. I started my own practice and sat in an office and didn't have any patients, and started reading books. Like a new case would come in, and I would be like, I have no idea. So I'd read the whole chapter on the shoulder or the whole book on the shoulder from Shirley Sauerman. And then I'd digest that. Then a back pain patient would come in, and then I'd reread all my Stuart McGill stuff and the application of that, so I could try to put together whatever it was, right? So I met you and other people that, other of our friends that were professional athletes. They started trusting in me more. I started getting panicked because I was like, hey, there's a lot of things I really don't know, but hopefully nobody else knows that. And that just kept driving my desire to learn more and more. And at the time, it was really just kind of all different facets. That's when I started the fascia journey with Tom Myers. That was my first fascia book that I really picked up and learned about. From there, I read another book that Mark Lindsay co-wrote, who's another big sports chiropractor and Canadian, really incredible therapist and person. And that's when I got my introduction to Guy Voyer. In the back of the book, they were talking about pumping of the knee. They did a case study on an ACL, and they were pumping the knee on the table. This is in a book, right? So I'm like, wow, that's really interesting. I wonder what that's all about. And then there was an Eldoa picture. The Eldoa picture was his old manual of stick figures, which was a stick figure drawing of L5S1, which is the very famous one with your legs up the wall. And I was having really bad back problems. And I just started doing it based on a paragraph description. And my back started feeling better, like within a week or two of doing whatever it is I thought I was doing. So I looked up on the internet if there's anybody that knew Guy Voyer in Orange County, and I met a really smart acupuncturist by the name of Melvin Tan, who he's gone on his own. He's had his own journey with professional sports and surgeons. He actually has been at a surgery clinic helping with the rehab for adductor repairs and abdominal repairs because of his understanding of the deep anatomy and all the anatomy of the abdominal wall and beyond. So I had him over to my office. This is when I was over on Von Carmen, and he sat down on the other side of the desk and was like, hey, this is a long journey. He had already been studying a couple of years with Guy. I'm like, okay. So anyway, I looked up the next course, and it was coming to LA. And that was a course on the knee, which was like a teaser course on all different facets of exercise related to how to rehab a knee. And that's when I met Guy in June of 2011. And then I sat through a course where I had already previously had 2 ACL reconstructions myself in my career. And I was like, oh, I know something about the knee. Plus I went to chiropractic school. Right? And then Guy starts rifling through all these ligaments and tendons and things and fascia. And I was just like a deer in headlights. And I was like, okay, wow, this is really humbling. I don't really have a clue about the knee apparently. And I need to decide what I'm going to do. So I decided to study every night and kind of move forward with my career that way. That's how I got started with Guy stuff. And then I did it 4 years of back and forth between New York and LA, taking courses, all the time. And then I graduated to the next level, which was taking courses in Montreal, which is what you brought up, which is where his official school at the time was located. And that's where we were able to study the upper level stuff, all the viscerology stuff, and all the craniosacral stuff and other things. And then I started teaching his Soma therapy program in 2016, which consists of the pumping, treatment of the fascia, treatment of the tendon and the deep ligaments, and then the 4 diaphragms, the 4 principal diaphragms of the body: thoracic diaphragm, cervicothoracic diaphragm, pelvic diaphragm, and then the cranial diaphragm being the last. And that kind of rounds out the 13 courses that I teach in the United States.
Yeah, that's great. So then you started teaching the courses, and you started working with some of the NHL teams. Kind of take us from there as far as the adoptance, the benefits that you saw, and then let's kind of progress that into sharing a few of your slides and just kind of talking a little bit about the background of fascia, fluid pumping, joint pumping, fluid dynamics, and then kind of where you're at today. And then there's a great question that we were having, before we hit record, which I was trying to press record even before that, so we didn't miss any of that, just as far as your thoughts, even in the last couple of weeks, as far as epiphanies with regards to some of Tim's SPRT work, and your thoughts on that.
Sure. The first question was, the sport. Okay, so I think really what had happened was there's a lot of chiropractors that were treating teams and a lot of chiropractors treating athletes. And I think the application of the pumping is really what started separating me. And that was because it was it's a quasi combination of an adjustment over and over and over again on a micro scale, which the goal is not to move the bone, which happens, but it also creates a change in the pressure at the joint, which moves the fluid and creates space. If you get space into a joint that didn't used to have space. Everybody feels better. And then if you want the coup de grace, in my opinion, and so far in my studies, if you put the juice back in there, now you've completed the puzzle of returning it to a more natural state. And that state is that state of the capsule and the fluid being in the joint to, create the space at the hip joint or create this part of the space at the knee joint. It's not all just the hard collagen-based structures. You've got to have the fluid. That's why the knee's not collapsed on itself. That's why the hip's not collapsed on itself. It's not just the labrum or just the meniscus. That has to be completely soaked with water inside the collagen tube, inside the fibers, and also between them. And that's why we're a hydraulic being. That's why we're also electric. We're electric because we have so much water.
Yeah. Yeah. And that's really the essence of manual therapy, right? If it's done right, you're moving water.
That's right.
You're literally moving water.
That's exactly
and
right.
space has always been my goal as well with everything that I do, and sometimes better than others. But at the whole goal behind that is when you can create space, fluid moves, things can pump, and life happens, right? And we are electric beings, and there's only one way to get that electricity through, and that's to hydrate it.
That's right. That's it. Are we?
Yeah. If you don't hydrate, you can't vibrate, right?
There you go. Yeah, I love that. Okay, so then it wasn't just an adjustment. It wasn't a 15-minute treatment. It became this like methodical wave that's being created literally in the body, which is part of the pumping mechanism, which is to oscillate. I don't like using that word, but everybody understands it. To oscillate the fluid pressures. And that's how you change the thixotropy of the fluid, especially in a synovial joint. If you let it go to rot and you cast it, then the stuff thickens. And then if you start to put it through movement, it starts to thin again. This is why movement is medicine and motion is lotion, and CPM devices from 1990 when I first had my ACL, when I woke up for my ACL and I was in that little silly machine that was like partially. It's the right concept. It's not complex enough for what we really need for proper joint mobility, but hey, it's better than just sitting around. So,
which is how they used to do it, right? It was almost,
One,
it
two,
was weeks,
two.
if not months, in a cast after an ACL, and nobody ever recovered, right?
Right. Exactly. So then the athletes started telling the team like, hey, you need to check this stuff out. And the short of it is, they recognized that it was something different, that athletes really liked it. And then they were a little more open to people like me coming in and giving education to, this is the most beautiful part about the pumping. It's not just a DC thing. It's not just a DC thing to do. It's like PTs, ATCs, all of the above, massage therapists, everybody can pretty much apply this under the laws because it's not a manipulation. So then that brought a little bit more kumbaya, right? So this whole sports medicine team approach that everybody was trying to push in the, early 2000s when I first graduated and then beyond. But was it really at the time? Tim knows way more about that than I do. In Tim's version, 100%. And other people's version in professional sports, I would say, you're almost there, because we were all just doing our own thing. But once I think this brought down a lot of walls, because it was, because the chiropractor thing, right, with the ATC running the show, but it all became like all of us working together, and then that really evolved now into how I got my job with the 49ers. I got my job with the 49ers because of a PhD, a really smart guy with sports science. You're seeing more and more of these that are being in charge of the whole mechanism of the team, from nutrition to recovery to the electrical modalities and PEMF and whatever else you want to do. And the biggest thing that he taught me, and the reason that I was there and still there, is soft tissue injuries are what That is the biggest variable in professional sports injuries. They know exactly what to do with a fracture. They know exactly what to do with a labrum tear. They're out and they have surgery. Those are ones and zeros. You don't need a brain for that. You just have to, like, get them to the surgeon. But you have this big gray area of soft tissue injury. And what he had seen and noticed statistically, because these guys are at a whole other level of like numbers and number of days back from a hamstring injury or number of days, whatever it was. And he knew and understood that if you had a mastery of the soft tissue, you could change the number of games, day, hours, whatever lost. And that matters. And that matters in sports. Yeah, money, winning, all the above. So that's really how it got put on the map, being applied on a weekly basis in a locker room or in a PT or in their physical therapy area. And if you didn't fit the surgery box or then it was like everybody was getting pumped. I educated the entire staff there. They all do pumping on a regular basis. And it's really statistically changed the outcomes for how long people are out for a soft tissue injury. That's kind of how it all came to fruition with an actual team applying.
So maybe we can go back a little bit, and you can pull up your slides and your deck, part of your presentation. And I know that this isn't the exact presentation that you're going to be given, but maybe you can just give everyone a little background, a little base understanding. I know a lot of us think that we know about fascia, and you hear fascia, you don't hear, you hear hyaluronic acid, you hear, other components of the matrix, but you don't hear as much about the fluidity component. So maybe you can just kind of pull up your slides. Can you just give a base 101, what you maybe thought
Sure.
that you knew about fascia, or even for those who maybe have, heard the terminology, but they just, haven't got an in-depth discourse on all that we kind of know now. And I know that it's a no pun intended fluid process. We're learning more and more every day, just like with the rest of science. But could you maybe pull that up and run through that a little bit?
This is an old presentation, and I say old only because I'm trying to find different ways to get the same message across. It's all about the messaging. Some of these things strike people in different ways, and I'm trying to meet everybody where they're at. So hopefully I can go through this. We'll stay off the first. I mean, there's the gags, there's the hyaluronic acid. I'm going to give a moment of tribute to one of the greatest influences on my career, Guy Voyer, who passed this last June suddenly from a heart attack. And this is where all of this was like common knowledge to him. Like, he's saying the word fundamental, or he's saying the word fascia in that picture. And it's all about the body being holistic and complex and global. And it's how everything is linked together. That's where I got the name for my company a long time ago. It's about the links. That is what we need to master in order to have total harmony of the entire body. It's the links. It's not the individual pieces. Although the individual pieces sometimes need specific attention, it's really about the links. And the links are the connective tissue. And that's like the more common terminology for the word fascia, or for the term fascia. What is fascia? Connective tissue, yes. The problem with the word connective tissue is that you think only in the physicality, in the physical constructs, in the collagen. But if you look at, I don't know if you can see my cursor, but if you look at the first word,
Yep.
Fibers, that is the collagen. That is what everybody spends a lot of time studying, which is really great and awesome. But the other portion of fascia is the matrix, John, which you just mentioned, and that has to do with water management, and I'll get to that in a couple of minutes. And then there's also another whole subsection of fascia, which are specific cell types. And this is how fascia is directly, the health of our fascia, quote unquote, is how healthy our immune system is. Everybody talks about the fibers. I give this a slide just so everybody, this is kind of like it's principally collagen. 80% of fascia is 10% of the body. These are all the things from a fibrous perspective that we identify with as fascia. Ligament is fascia, tendon is fascia, the aponeurosis, covering of the muscle, right, which is also a continuation of the tendon, the periosteum, which is also a continuation of the tendon, because that's the link. Periosteum to a tendon, to an aponeurosis, to a tendon, back to a periosteum. That is the functional link in a muscle. The muscle's in the aponeurosis, but it's not the only constituent, as you can see on the right. Dura mater is a very fancy kind of fascia, and cartilage as well. And I put here, when you talk about tensegrity, which is basically a balance of tension and compression, these fibers generally resist tension, pulling things apart. This is how you can go to space and not fall apart, because you have this part of your body, this tensile part of our structure. The cells, specific cells that are considered fascia, because they also come from the mesoderm. Fasciocytes, this is a big word that's being talked about more and more in fascia research and everything else. These are the sites that actually make the fascia. Fibroblasts. I highlighted adipocytes, which I'll talk about in a moment. Your immune cells and the reticulocytes, and those are the fancy cells that create scarring. So all of these things are considered part of the fascial system. The adipocytes is interesting because I think when we think adipocytes, we think obesity, fat, maybe some insulary things of the viscera, but there's a big biomechanical and functional reason for having fat in certain places. This particular slide I chose, John, you've seen this presentation before when I teach these, how to pump these different areas. This is the scapula. That's the subscap just in front of it. That yellow space is a big greasy area full of adipocytes and a mixture of water and fat, which allows the scapula to slide on the next layer, which is the serratus. So this is the scapuloserratic space, which is full of greasy fat. And then there's another layer between the serratus and the rib cage. So when I teach this, it's not the scapulothoracic joint. There's actually two joints here, scapuloserratic, serratothoracic. And this is important for biomechanics and functionality and performance. So that's another type of fascia. Management of water in the matrix. This is where you start to get all these confusing words and things, John. Macromolecules that bind water. I mean, basically, one of the main functions in the extracellular matrix, which is what this is short for, is the binding of water to create space between the cells and other places. This is not intracellular water. This is extracellular water. And it can be in different places and different forms. One of them's in the collagen tube, which is interesting. Now we're back to the fiber slide. And part of the fiber actually has water in it, especially the collagen fibers. And then you have these different mechanisms of keeping the water in. Those are just specialized either enzymes and macromolecules. But the importance of it is these help bind water. If you look into different parts of the body, different things bind water. I can skip this for now. And then this is one of the questions that I always ask after just that little brief synopsis. Which of them contain water? Fibers, cells, or the matrix?
Yes.
Yeah, exactly. All of it. All of it. Which is why this is an important side of the coin. The basic functionality of the fascia as a whole and the orthopedic sense is creating space and enabling flow. If you put these two things together, exactly like Tim just was talking about, that's how you have proper harmony of the entire body. This BioTensegrity concept, which again is a combination of fluid and fibers, and now you have this balance between things pulling together and things keeping things apart via the liquid. And that's how BioTensegrity works. That's just a very quick overview of that. The goals, and this is where my epiphany came, because, I try to teach, like, you got to have command of the deep ligamentous and joint structures in order to alter patient movement and recovery and rehab. And I teach from the deep, because the expression in the tissue can change superficially if you have a dysfunctional joint deep inside. And that sounds like a chiropractic thing, but it ultimately is just the way that we're built, right? Deep to superficial, or you can look at it in the reverse, from superficial to deep. So in my more recent studies in the last couple of weeks, from a French MD by the name of Bricot, Bricot, who's like the godfather of posturology, which is a lot of neuroadaptive things to alter our posture. One of the aha moments that I had reading that the other week was, if you look at the exteroceptors, which is all of the information from the tissues to the brain, combined with the proprioceptive information, not only does that all of those receptors, by the way, are all in the fascia, including the muscle spindle. So even the muscle spindle is not in the muscle. So all the other receptors you can think of, proprioceptor or exteroceptor, are all in the fascia, which means if you want to have a better 80% of the afferents going to the cerebellum, you need to have high quality fascia to articulate the highest level of understanding of the joint position, et cetera, to synchronize and harmonize movement. But in Bricot's book, he talks about the three things that are fundamental to proper proprioception and exteroception. And you can start with the skin, or you can use the fascia, ligament, tendon, because that has a lot of information, or you can have the deep capsule and joint. And that's the SPRT. So if you want to make a change here and now, Tim can tell you for hours about the changes that can be made by applying tape to the skin to help override the system and change the system in real time. And then, of course, you can adapt based on that. Or again, you can go to the deepest part, which is the joint capsule and the amount of fluid, and you can work at it from that perspective. All of which needs to be covered, but all of which can be a way that we can manipulate the afferent information for neuromuscular control. And that's kind of like how we're all already in the same boat, and we're just looking at it maybe from two different ends.
That's great. Great explanation.
Oh, thank you. The pumping, the osteoarticular pumping that I talked about, we're trying to move the fluids, maintain the spaces, and enhancing the micro movement, John. And that's the teaching, or that's the hands-on component. I'm not going to go through the rest of this stuff. I think maybe I'll talk just for a moment, John, about, the lymph gets a lot more notoriety than the fluid and the fascia, but it's all part of the same continuum. So I'll spend a minute here or two. Tissue fluid becomes lymph. So the feeder tributaries to this river system, we'll call it, it's got a great label, the lymphatics. It's actually where the interstitial fluid, or the extracellular matrix fluid, that's where it empties into. So we already know the power of lymph, both orthopedically and health-wise and other. So the suggestion is that if you can also utilize and change the interstitial fluid movement, which leads and dumps into the lymph system, and then you also treat and affect the lymph system, now you have efficiently cleared, cleaned, or recycled or changed the fluidity of the entire body. So it's not just the lymph, because that's just a fancy name for extracellular water or interstitial water that's now going back to the heart. That's all part of the same system. Okay, and then here's the question. Here's 1 second, Tim. So the question is volumetrically. This is a question I'll ask always. How much of that fluid that I'm talking about percentage-wise is in the lymphatic system versus how much is in the interstitium percentage-wise. John, you've probably already heard this. Maybe you too, Tim.
No,
You
have
haven't?
not. Have not.
85% of that fluid's in the interstitium. Only 15% is in the lymph system.
Wow.
So that's why it's important to move the fluid in the tissue and the joints and not just the lymph. Although the lymph's really super powerful, but the rest
Well,
of the puzzle.
it's also a passive system, right? The lymphatic system. So, we need to move to make the lymphatic system work, or you need to manually move it,
That's right.
right? Yeah.
Mm-hmm. Yeah, the rest of this, John, is very specific to the knee and stuff, which I don't think is
Yeah, and I can see smoke coming out of Tim's ears right now because I know that he's got 100 questions and a number of things that he wants to discuss. And once again, we were kind of talking right before about your epiphany in the last couple of weeks, so we'd love to get into that. But a lot of this, if you are a practicing, chiro, PT, athletic trainer, trainer, athlete who's trying to better understand, this process and kind of what you're talking about, it makes a lot of sense. It also sounds very complex relative to what we've learned and how we've learned it. Can you maybe, whether it's going back to the shoulder and the, and the scap, or, you're just on the knee, can you give an example just so that everyone can better understand how you tie that all together? Somebody's got a shoulder. You're working with a pitcher who's got a shoulder or an elbow. You're working with a pitcher who's got a low back. You're working with a hockey player who's got a hip or an adductor or a knee. You're working with a golfer, who's got a back.
Mm-hmm.
Whatever your example would be, because you use this for anything and everything that comes into your clinic, whether it's high level athletes or just individuals who are trying to stay healthy and be able to go out and play a round of golf or throw a baseball with their kids. Can you briefly, somewhat, kind of try to explain? Somebody walks into your office, what is this process? Because there's a pretty thorough assessment process that you take people through, especially as it relates to hips and the pelvis. And how would you explain to an athlete and what's an easy case scenario for you to kind of give a better understanding of how this process works and what you're doing technically?
On the treatment side or on the exercise side? Treatment?
Let's start with the assessment side, and then into the treatment side, and then how the exercises progress from that, because it's a pretty complex process. There's an assessment, then you do the pumping, and then you leave them with the Eldoa and the Soma exercises. In just a few minutes, try to take us through that process.
Sure. I mean, when we talk about the tensegrity puzzle of the body, we consider the pelvis to be the center of both the hydraulic and the tensile universe. And that's not because it's in the middle, but because you can look at any chain from any book and chain, whatever, and they all end up being influenced directly or indirectly by the pelvis. Whether it's the big toe, my cranial sacral mechanism, my scapula via my lat to the pelvis, my knee via obvious things to the pelvis. So the assessment is Fred Mitchell's understanding of the pelvis, which is an American DO from 60s and 70s, and then Guy took it to another level. So it's like this: you got to really understand the biomechanics and the differences between an iliosacral problem, which creates a short or a long leg, or whether it's a sacroiliac problem, which doesn't create a short or a long leg, but directly tethers your dura mater or pulls on your uterus or affects your bladder or rectum or whatever. So those pieces are super important. So that's where everything starts from, which is a combination of the biomechanics of the pubis and the left and right sacroiliac joint. That's like where the command center is. And then from there, we talk about the lumbopelvofemoral complex because those are inseparable. L4 and L5 are commanded and directly connected to the ilium via the iliolumbar ligaments. So L4 and L5 don't have their independence. L3, 2, and 1 do, but L4 and L5 don't. And in this complex osteopathy, and we talk about the lumbar, the lumbar that's dictated by the pelvis and that which is not. So you have a free lumbar, L1, 2, 3, and then you have the one that is connected to L4 and L5. And with the same exact conversation, now you can't separate the hip either because it plugs into the ilium. So now you have the lumbar, L4, 5, sacroiliac joints, pubic symphysis, and the hip that you cannot separate from each other. That's a big place to start.
It's huge.
Even with a headache, that's the first place for all of those reasons and others. So then it's, so that's a very chiropractic, structural, biomechanical assessment. Then it's just the tool in which I use. If the thing is dry and not moving, it needs some fluid and it needs some space. And that is where that's where I prefer to use the pumping, which takes time to make a change over the adjustment. Now, a lot of the times the pumping is leading to an adjustment if needed. And because I've prepped the capsule and I've moved the fluid and I've decreased the amount of pain, now the brain's not protecting as much. Now I can get a better adjustment. And the betterness comes from the longevity of the application of the adjustment, not just the fact that I adjusted them. And that's
great point. You gotta till the field before you plant the seed.
That's right.
And I think a lot of us miss that, and we need to pay respect to it. And it takes time, and it takes focus. But it depends, for a lot of us, and I'll kind of go to the extreme here. You're either interested in outcome or income, and I think you can have both. But first, that service, get the service done and create that outcome. You have to have a model that does that, in my opinion, if you want to be an effective chiropractor, sports chiropractor, ATC, PT, MD, it doesn't matter. So, I agree with everything you're saying, and I appreciate the education. Thank you.
Thank you. So, John, I think that's what starts the evaluation for everybody that walks in, and then to the point of how long does it take? What is the mechanism? How do you implement the exercise? It just depends on the hierarchy of an issue. If the issue is a compressive issue, like often happens in L5 or L4, like in a baseball pitcher or something, like if that is, until you unlock and create the space again, I'm really tentative and hesitant to have them do anything else. And it doesn't take that long if that's the only thing you're focused on. Because without the space at L4, if L5 is side bent or whatever, and you don't create the space again, you're going to have trouble forever, as far as I'm concerned. That's why we put them directly in the pool, and all the focus is for however many hours it takes to decompress that joint. You combine that maybe with the Eldoa, and now you're back to quote unquote square one, where now you have like this more movable, flexible, functional spinal unit or whatever. And now you can kind of move forward with what you want to do for rehab. But if the space is compromised, that's when you got to tread lightly, because that's how you tear labrums, tear meniscus, labrum in the hip. That's how you create more damage to an intervertebral disc, is you don't respect the space that's required. And that's, I think, a really important piece of the functionality and performance puzzle, is that space.
Yeah, I was just going to say, when you don't have that space, it's a ripple effect throughout the rest of the body. The body thinks that's what you're trying to adapt to, is no movement, and so it will gather healthy tissues into that central area of compression or a lack of space, and it'll pull everything in, right? I mean, it's the epic, or classic, I should say, fascial model, where you've got the guy with the body sweater on, right? And what area gets tight, it affects everything. I mean, it's that basic, but so true.
Right. Yeah, absolutely. So that's kind of the treatment evaluation part, John. And then there's specific things to create space. You mentioned the Eldoa. The Eldoa is really put Dr. Voyer on the map, because that's how we create more space in the spine, specifically vertebra by vertebra. We can do an Eldoa for a rib to open up the rib, the glenohumeral joint, the hip joint, all different. There's like 50 different Eldoas for the sacroiliac joint. Not even exaggerating.
Wow.
Like to be able to pull open different pieces of the sacroiliac joint at times when that's how the rubber meets the road. You can't come in and see us, 10 hours a day, every day. That doesn't work. But if you get them to really help themselves, they're also, it's part of the process of really truly understanding whatever it is that's going on from a performance or from a pain perspective, if you will. So that's the one type of exercise modality that I'll be using on the Saturday, is to go, understand a little bit more about the Eldoa. And that's kind of that's where I consider the key adjunct home exercise to what we're trying to accomplish. If space is the main problem, if there's other issues, obviously that needs to be, there's no Eldoa for the ankle, unfortunately. That requires hands-on treatment until that you've created that space and that fluid movement, etc. So it just depends on what part of the body it is and what exercise tool or selection that kind of fits this paradigm.
So I'll slip in something real quick here. Have you experienced fascial hopping?
Hopping?
Yes.
I don't know. I don't know what that word is. In this
I mean, it's just one of my athletes sent it to me, found it on the internet, and this guy's really into fascia and training people's fascia.
Uh-huh.
And I thought it was like, okay, this is an easy trial here. And based upon my study of fascia and how important things are to slide and glide, and having my body reach getting close to 70 now, and all the injuries from football and whatnot, I don't slide as well as I used to, my man. And so I'm looking for anything that I can do on the regular basis to help my body help itself. And so I said, well, I'm going to try this for 12 days. I'm not going to tell anybody, which is hard to keep my trap shut for that long when I find something that might be working. And so you literally put yourself in jump rope position and you stiffen the body. Like you're not using your muscles, you're using the fascial system, and you stiffen the ankle and you start hopping, and just like you're jumping rope, but without the rope. And you put yourself in Brugger's position, so you open up all the meridians and channels, thumbs externally rotated, arms externally rotated out, and you hop for 2 minutes to start. And you just literally hop. And I'll tell you, I did it for my hip, and within a couple of days, I've had terrible problems with my neck from football. It's all starting to glue together. And holy smokes, I didn't even work on my neck, and my range of motion improved tremendously.
Wow.
And so if I look at the anatomy and I look at how the matrix is formed, and you just start hopping, all those, your your peri, your epimysiums, all those things start to slide and glide with heat and movement.
Right.
And I would tell everybody listening to this to get up and try this stuff. And you don't have to go for 2 minutes. If 1 minute you're feeling cooked, that's fine too. But the key is don't bend your knees, don't bend your ankles. Use your elastic system. Use the fascial system, and incredible things will happen. So I just wanted to drop that in there.
That's awesome.
Because now I've tried it, and I'm going to challenge everybody out there in podcast world to give it a go and give us your feedback on it. It's the most simple mechanism I've ever used to get global mobility.
That's really awesome.
Yeah. That's my story. I'm sticking to it. And so John's not back yet, so let me throw in another one. Okay. I'm going to load you up as soon as while I can here. So you spoke about fasciocytes, and I was fascinated to read about the article that the Steckos did on, Carol Stecco specifically did on studying what shear forces do to fascia, and how shear forces stimulate the production of fasciocytes, and how fasciocytes stimulate the production of hyaluronic acid, which holds the water, right? And so a really cool thing when we're doing manual work, we're actually creating shear forces across the face of the surface of the fascia. And so to stimulate more fasciocytes, you can't have enough of them, right?
Right.
it's a great way to understand that, hey, not only are we getting this physical change that we can see and feel by improved function and range of motion, but what we're doing physiologically is powerful.
Right.
I was wondering if you could just speak to that for a sec.
Yeah, I mean the fasciocyte mechanism, it basically comes with its own water attracting signal. So you can't just create more cells, you got to create cells and the ability to bind more water, which is just that's like the genesis of healing. I mean, those types of things, like on the micro scale, is the shearing that we do potentially in our treatment, but it's also a combination of, that's why you need to utilize and exercise in specific ways in a progression after an injury, so you can build up the resilience in the collagen fibers to get back to what your norm is post-injury, post-tear, whatever it is, whether it's the proximal tendon of the hamstring or the Achilles or what have you. That's all part of the healing mechanism.
Just makes perfect sense. That's wild. That's cool. So another thing, that's super trendy, and though it seems to have some pretty good science behind it, is the red light and infrared lights. I'm wondering how that works, and if you utilize those modalities in working with fascia, because certainly that deep heat, that microcirculation, isn't doing anybody any harm.
For sure.
So I'm wondering if you've found any ways to work with fascia in your style, and then adding in the infrared or the red light, depending on what your objectives are.
The infrared, which was that, Tim? The infrared sauna or the infrared light?
Infrared lights,
Infrared light.
or sauna. Either way, I mean, it's doing the same stuff.
Right. Okay. For how we use, I think I mentioned this to you before in probably a side conversation. It's the PEMF specifically is the one that drives more of the fluid movement as far as the research shows. Now, the mitochondrial function from the red light and the rest of it is like super important for many reasons that I don't understand. So I don't really use the red light specifically from a fascial perspective. I use it for a lot of mitochondrial health or what have you, exposure and things of that nature, especially in the skin and other things. So that's not really my expertise as far as modality goes. But the PEMF, because of its electromagnetic portion, that can also move water without you having to move. You know what I mean?
Right. Oh, absolutely. It gets the molecules dancing, for sure.
That's right. So that we use in conjunction with a lot of treatment, and that is a big part of, if somebody really wants to cover all facets and a lot of their downtime when they're not being treated, not exercising or what have you, that helps also move the fluid in the layers and within the collagen tube, which is part of what we're trying to accomplish through movement and treatment.
And right along those lines, that's where frequency becomes very, very important, right?
Absolutely.
So PEMF, there are machines out there that are general PEMF, and you really can't set that frequency. And I think that's the magic for me with PEMF. If I'm going to use it, I want to understand what frequencies are going in there, and I know fascia loves the 60 hertz, right? Fascia vibrates best at 60 hertz. Muscles different as well. So understanding that our body is all about frequencies and different frequencies working together, you can kind of create recipes based upon those frequencies to address specific tissues in the body when you're rehabilitating or just trying to reach homeostasis.
Right. And so what I have used for that, only recently become more aware of, is the frequency specific microcurrent, which is the same technology, which is based on all of the Rife frequencies, right? Like you have a different way to harmonize the tendon versus the ligament versus the bone. I originally started using it for bone healing. That's been a long time in professional sports. Like you get a break, you want to use frequency specific microcurrent to help increase the collagen and mineral deposition to heal the bone faster. And then, now it's starting to morph into, hey, there's other ways and other frequencies to stimulate different parts of the anatomy. And I think that all makes sense. I think Rife, obviously, and others were way ahead of themselves when they were Speaking
They
about
got themselves in troubles being a little too far out in front,
exactly,
right?
exactly.
So watch it, buddy.
That's right. That's right. That's right. Crazy.
Oh, that's wild. So, how is your body doing? And if I could ask this question, if you've been at this for a minute now, I think about 20 years in practice, maybe a little bit more. And
Yeah,
um,
crazy.
how are you looking at the body now compared to 10 years ago? If I'm coming in for say a low back issue, have you changed in the last 5 or 10 years how you approach kind of your whole setup when you're working with people, or is it just kind of a continuum?
Great question. It's definitely a continuum, and I'd say the biggest difference in the last 5 years has really been related to not only a further understanding of the biomechanics of the sacroiliac joint, which I was talking about before, and how they interplay, but I'm gaining better knowledge and understanding of how to apply exercise to meet the same desires and goals as my hands-on. And that's where this whole pool thing comes in, and some of these other exercise, like on a springboard floor. I've learned a lot from a really, really smart ATC out of Philadelphia, Bill Knowles, who's like the man for rehab of like post-surgical knees, especially in all sports across the world, from professional soccer. He speaks at FIFA every year.
Wow.
NFL, NBA, all of them. And I was introduced to him years ago because we were working on athletes together, anyway, it basically became, this guy was accomplishing a really incredible end result after an ACL injury or whatever it was, and no hands-on, Tim.
Holy smokes. Can you give us a little of that recipe?
I mean,
What's he doing?
early movement pattern, like immediately in the pool after surgery, like the day after, against
Oh, no kidding.
against everybody else's recommendation. Yeah, because it's waterproof taping is like,
Yeah.
that's not rocket science.
Yeah.
You know what I mean? To keep the water barrier, to keep the water out. And then literally he goes through some movement patterns that are ingrained to try to bypass the injured joint. He teaches, or the injured tissue, he teaches that for every structural orthopedic injury, there is also a direct consequence to the brain. And
Absolutely. The homunculus.
Right. And we're obviously not talking about concussion. I'm talking about hurting my knee and how instantaneously, and he's got references on ACL and what happens with the eyes. After you sustain an ACL injury, your eyes become a hyper area of activity in the cortex, because now you have to be so afraid of the ground.
Surviving. Yeah.
That's right.
Wow.
And so you have to unprogram that. If you don't unprogram that, then forever the risk of injury is at a higher level than you've actually relaxed the state of alertness or alarm that, hey, everything's okay. My limb can handle itself without the help of my eyes. This is why during the later phases of his rehab, he's actually specifically not using the eyes, won't allow the eyes, which would naturally go look at the foot or the knee when it starts to land and do things differently because it wants to be involved in the process. Then you can't catch a ball.
Right.
You can't
It's a little bit difficult.
That's right. If your eyes want to go to your knee or go to the ground to see what's next, your ability to do that, whatever skill, becomes less. So this guy is basically doing all of the rehab from the day after surgery all the way back to the field with hardly any hands-on, Tim.
That's just so beautiful. And I've been such a fan of what we call aqua jogger, right? We've got a belt that you put on. It's like an old school ski belt. And that's really encouraging me because I don't see that a ton in people's practices, is getting people in the water. You reduce gravity by 66%. You increase resistance by 75% relative to air. And you're in a medium that's decompressive.
Say no more.
And what did you say about space?
Yeah.
I mean, is that critical? So
Right.
I guess I'm going to keep that going, and it's just great to hear. There's a guy named Glenn McWaters that created a system of deep water running. He was a Vietnam vet, and he was a horse trainer, and he had a terrible knee issue, and saw his horses out in the big pond, and hooked himself up with a floatable vest. It was called the wet vest, and we're talking back in the 80s. And this guy started the deep water running thing, and it just, I mean, of course, I'm a water guy anyways, but it really hit home to me. And so I've been using that in my practice ever since. But hearing that this guy's getting such great results, I'm going to get my people in even earlier now.
Yeah, definitely. And you know what, Tim, to round off the list of things that happens when you put them in the water, now you get all of this incredible sensation from your entire skin body.
Yes.
Which lowers the threshold of pain, because now you have all this afferent, proprioceptive, extraceptor information, and now that the importance of pain goes down like tenfold.
You're wholly supported in the water.
That's right. It lowers all the fear, and then as you take them through different, just simple things, you start allowing the joint to be able to move freely, and it's really quite an amazing process.
Yeah, I think now I'm kind of seeing it visually a little differently now, and seeing the compression happen while you're in a state of movement.
Right.
And we know, based upon what you've taught us and what's in the literature, that compression and movement is huge for the body and its ability to move water.
That's right. So that really has become what is different, to answer your question. That's what's different in the last 5 years is really finding other ways to empower the athlete, and to also go after the subconscious mind, which is part of the injury mechanism.
That's wonderful. I've absolutely found this to be true, that the more you involve the athlete in their own care, the more that you listen and open your ears up to what they have to say, so that you can stick and move and adjust your treatment to not what's in the book, but what's in that person's body and in their mind on that day. So great tools. Thank you.
You're welcome. Yeah, no problem.
So couple things before we wrap. Number one, I don't know if you got a chance to kind of really go into a somewhat of a detailed explanation of what joint pumping actually is. Like, once again, back to that example of a shoulder or a back or a knee, whatever you think would be the easiest way to kind of, depict or illustrate or share that story, I guess. How, like, what are you doing when you're pumping, and explain that, as you grab a shoulder, as you're pumping, the shoulder or the knee,
I'll do a weight bearing joint, and one that doesn't have an Eldoa, which is really either the knee or the mortise or the subtalar. And without being too confusing, talking about them all at the same time, the global concept is the same. I mean, it is part like you're distracting the joint, which increases the volume of the joint, micro scale, especially a really stuck one. I just saw a goalie for a team yesterday who his mortise was so compressed that there's no way that thing had been decompressed 6 months, a year. It was not moving. So for me to try to open it up very specifically and it not move, I had to do it. I mean, I'm a counter because I have a little bit of OCD. So I think maybe 200, 250 yesterday. And then by the time I got to like 100, that's when I could start feeling it just barely gap, to use a chiropractic term. And then very quickly from 1 to 250, it went from, there's no way I was asking him if he could feel it, till all of a sudden it was like globally opening and closing. But during that time, I was pumping the ankle joint. He also had a same side Achilles tenderness that had been bugging him roughly around the same time that his ankle didn't feel right. So now by distracting the calcaneus and the talus away from the bottom of the mortise, or from the bottom of the tibia, now I'm pulling on the entire Achilles complex over at 250 times. And if I pull on the Achilles complex, now you're taking the tension model in your head where you think it's a bunch of strings, but now we know there's water in the strings and between the strings. Now I just moved all the fluid in the entire Achilles. I go back and touch his Achilles. not quite at the calcaneal insertion, just right around that area. And all the tenderness was gone. I wasn't even treating the Achilles.
Wow. Wow.
That's because I moved the fluid that wasn't moving. Why was the fluid not moving in the Achilles? I would say because the ankle wasn't properly pumping the tissue because he had a lack of range of motion in his ankle. And that dryness and dysfunction of the tissue will continue all the way up the chain as long as that ankle remains not moving correctly, because it's supposed to be the driver for the chain to pump the chain, not me. I don't have to do that on everybody. Is that
So you can
it's so critical, right? Dorsiflexion, the ability to dorsiflex to clear the knee and clear the hip.
right.
Yeah.
So if you look at it from a part of a regional interdependence model, that's great. But then you start linking these things together with the fluidity, and then it starts making sense. Like you're like, oh, okay, that's maybe why and how that particularly works. Now we created space in his mortise. We really helped the fluidity of the entire Achilles tendon. Now you have better information from the receptors going to the brain. Now he can move more efficiently.
So from an application perspective, because you can use this on anything and everything, just rattle off a list of every injury that you can use joint pumping for, and basically what you're yeah.
Okay, I'll start distally. I mean, any of the turf toe, sand toe stuff. I mean, that's like, you can't just get in there, as we are all chiropractic. You can't just get in there and yank on that thing. If you do, you're going to get punched in the face. But if you do this micro distraction specifically of the joint in question 100 times, 150 times, they won't even get any sweat on their brow. And then at the end, the whole thing opens, much like an adjustment. Now you've helped the chain and you've helped the joint that hurts. So that's a big one. Liz Frank joint needs to be mobile. It cannot be rigid. I can't tell you how many NFL and other hard ground players think it's okay that until they blow their Liz Frank for it to be completely inflexible. That's why you blow a Liz Frank, because it doesn't have, it's the path of least resistance and an upstream or a mortise subtalar mega restriction. Now you're going to go bust your foot planting. Like, how is that even possible? Obviously, these guys and women are strong and all the rest of that, but so is everybody else on the field. So Liz Frank needs to have like this. I wish I had a model. Like, we do this like almost like this towel twisting between the metatarsal head and the last row of the tarsals, and you're creating this lemniscat between them that works. That's not just the open space. Now we're talking about torsion and spirals, since I'm sitting here with Tim Brown. You know what I mean? Like you got to create that. That's how the body moves ultimately. It's not left, right, forward, backward, side bend, rotation. You got to put them all together. But that's a little bit more difficult.
So you just used the word lemniscat. Can you explain that real quick?
I mean, a lemniscat is an osteopathic term that is exactly what Tim has been talking about with spirals. The difference being the body works in these torsions. The bone is a classic example. The bone breathes. That's not just an osteopathic thing. The bone actually breathes. That's how it maintains its health. The bone, the femur, for instance, is also not totally rigid. Without all of its attachments of the adductors and the abductors and the this and that bone is flexible. You need to have the stimulation from the musculoskeletal system to properly stiffen your femur. So the lemniscat concept there is this breathing that happens in a bone where it gets long and skinny because it's torsioning on either end, or it gets short and fatter. And it does this constantly. You can't see it with your eyes. You can feel it. And the easiest places to feel it is the fibula, the clavicle. Those are the easiest place to put your fingers on it. And you can feel this expansion reduction in osteopathic terms of the bone itself. That's required. Like an old fibula fracture, as we're moving up the chain, if it no longer can lengthen when you go into certain movements, inversion is supposed to go a little longer on that side and all that. If you lose that, you lose the adaptability of the foot to the ground. That's why when I teach about the ankle, the ankle ends potentially, if you want to try to truncate things, where the fibular head attaches up at the tibia at a minimum, let alone the tibia at the knee, because that's the same bone at the bottom, etc. So that's the application. A big one is pumping of the fibula. The fibula's got to move. All of these bones are connected via these elastic components. They're also called ligaments. They all move together. The bones are really floating in a ligamentous matrix with water. None of them touch, with the exception of the cranial sutures. Those actually touch, even though there's still a little bit of space there. All the others, there's an insulator. Not truly an insulator, but an insulator of not touching, which is the meniscus, the labrum, and water. That's it. So that's why the space is so important to maintain.
Explain.
That's great stuff.
Talk for a second just about, as you're moving up the chain, and you just mentioned the word ligament. What we know about ligaments now relative to what we thought as far as the densification of fascia, and that just being, we used to think that those were, somewhat relatively separate structures, I guess, to create guidance for the joint. Can you talk about that? What we realize now?
I mean, sure. Yeah. I mean, the way that Guy teaches the ligament is the intelligence of the movement. It's not the stopper of the movement. It's not just a real simple rope.
It's not a seatbelt.
No, it's not a seatbelt. Like, that's how biomechanics gets explained. Yes, it does stop the certain sliding in certain directions, but way before it stops or starts is all the gray area in between. And that's where all the information to the cerebellum comes from. Hey, I'm getting tighter here. Now it's time to pick up my toe, or I'm running, or whatever. You know what I mean? Like, the ligaments provide a barrage of information upstairs, which is why the ligament needs to be healthy and not tight. A tight ligament doesn't provide a whole lot of information to the brain. It's the adaptable ligament that provides a boatload of information upstream, so we can move better and better sequence our movement.
And the best way to create a healthy ligament
is to pump the ligament. If it's part of an injury, right? Like, if it's, this isn't moving, my tibia doesn't internally rotate. Okay, first thing I go through is, in my head, what allows the tibia to internally rotate besides just at the joint itself? Okay, well, that means you got to have a flexible biceps femoris. You got to have a flexible IT band. Both of those will or will not allow the tibia to internally rotate. Oh, wait, what about the navicular? If the navicular doesn't internally rotate down at the foot, the tibia can't internally rotate. So then you start looking at these pieces. I'm trying to accomplish this goal of my eval of lacking internal rotation of the knee. And then you go through a step-by-step process of joint first, and then ultimately, how can I affect the ligament to allow that mobility as well?
So we're working our way up. We're kind of at the knee: ACL, MCL, PCL, meniscus.
The biggest learning points, I think, for me with the knee over the years has been the micro movement of the knee dictating the macro movement. And that means simply the rotation of the knee, the A to P slide is all really important for knee flexion and extension. So in a rehab case for us, we don't do any flexion and extension. We only work on the rotation and all of the slides of the knee. And the default is, or the side effect is, you have better flexion and extension. Because remember, on flexion, you got to have a lot of tibia internal rotation. And on extension, you got to have tibia external rotation. So that's a real important piece. All those little micro movements of the knee are really important for the overall functionality of flexion and extension, not just pure flexion and extension. I think that's a big aha moment for me during rehab and things. And you can go directly to those. If you got an ACL injury or an ACL post-surgical, you can start rotating the knee the day of surgery. And you're starting to like rework the flexion and extension without even going and putting any tension on the ACL, which, you should be putting stress on the ACL from day one, Because, the guy, when he finishes up the ACL surgery, grabs a hold of it with his hand and pulls on it as hard as he can. And then we get into rehab and we're like, hey, don't put any stress on the ACL, man. It's like, hey, if you want to build collagen and you want this ACL to be robust, you need to be putting not 12 pounds of pressure to tear it again, but some micro amount of stress to increase the fasciocytes, to increase all of that. So now you're starting to get a more robust ACL at the end and not a wimpy one. If you stay away from stressing the ACL until the graph that the surgeon gives you, which is at like 6 months, you've missed 6-month window of creating a more robust ACL.
So I think
and
it's pretty evident.
The pumping is a micro stress. The pumping is a micro stress as well. So I can stimulate a ligament or what have you.
So I think it's pretty obvious, no matter what the injury or potential movement dysfunction or challenge, you can apply this thought process and this protocol, to that. Can you, and we could do this all day, and maybe we will at some point, go through every possible injury, condition, challenge that we see, because there's a lot that we see, especially working with athletes. We were at one point working with a pitcher collaboratively who had a UCL, and you were showing me how to pump the medial elbow and the UCL. And I think that's maybe a great way to explain and maybe kind of take us through. This isn't just gapping a joint. You aren't just taking the joint and gapping it to create a pump. There is, like Tim likes to talk about a dance. And I'm not very coordinated, so it takes some time, to learn that dance, the subtle art of having the athlete push into you to create some amount of activation or movement as you are creating another movement into the joint to create this pressure wave that's creating that pumping process. Can you just really quickly, once again, to try to illustrate so that people can get a better understanding of what this truly is, kind of explain that a little bit?
Sure. I mean, you're the ultimate goal of this is a joint between my fingers. This is bone A and bone B. The ultimate goal is to literally create a wave, a delay. If you move one bone one way and you let go of this one goes like this. If this one goes this way, you start to get this oscillation again at the joint, which the goal isn't to move the joint. The goal is to change the pressure to move the fluid. That, I think, is how it becomes this more of a dance. And we use the active component from the athlete. And to your point, for the elbow, we have them push because we're trying to stay well within the current physiological range of the ligament and the joint. That's why there's no guessing. Chiropractic, it's always like, how far do I really thrust, especially on an elbow, right? You're like, but if you get this whole wave of movement in all different directions of the elbow, then the physical capacity, the physiological capacity of the ligament plus the water, plus the synovial fluid, plus the capsule, whatever it is. That's probably the art of what you're talking about, John. And that just takes, at first it's very mechanistic, and you learn the basics of how to create this. We call this a delay. Like when you push your arm in a certain direction and you block the elbow or you block the wrist, it moves more proximally. And then I just follow that. If it only moves that much, I only follow it that much. There's no thrusting or guessing. And then as it gets bigger and bigger, now I know that the whole thing, it can take on all these different shapes, if you will, of movement. And again, it's the micro movement. It's not the flexion and extension as much as it is, especially in a pitcher. How well can that almost slide forward, backward, left, right? And the UCL example was, I believe, the elbow, after having been stressed over and over again into a valgus, there was actually a valgus contortion or change at the elbow that was never rectified. Then you do a UCL repair to a joint that's already slightly displaced. That's how you tear another one. So it's like you got to try to restore the normal mobility, and ideally before surgery. That's all part of the prehab. That's all part of pre-surgical intervention. Why would you do that? Because the more fluidic you can get the joint and the tissue, that's when the surgeon comes back to the athlete and they go, wow, I've never really had that easy of a time getting into the shoulder or the
Right.
knee or the
Yeah.
hip. That's why. It's because it's all full of fluid.
As opposed to the opposite end where it's inflamed,
Right.
and now outcome is marginalized because they're going in on a hot joint.
Right. Right. And
So
everything's
yeah,
stuck together. Now they got to pull everything apart.
right,
Right. Instead of like,
right. And the body's already like this. There's defenses up, and so the body doesn't know it's having surgery. It thinks it's getting stabbed.
right.
So right,
Right.
so everything's going to react to that trauma on top of the other trauma that got you there to begin with. So yeah, I appreciate what you're saying. I have one question. You talked about athlete helping you compress a joint. Does that mean they're pushing into you as you're pushing into that joint?
Oh, I didn't mean to use the word compress. I meant pushing into me to create a slide at a joint so I can go with whatever movement that the
Okay,
joint has
gotcha.
afforded me. That's why we use the patient involvement, because without that, it's just you would just be guessing how much you can push and how hard you should push, instead of, oh, this is what the tissue is allowing it to do. That's where your starting point is.
Brilliant. Thanks.
Welcome, anytime.
So sounds familiar. So, based on that, and we've talked a little bit about osteopathy today. I think DOs currently have a slightly different skill set or focus as far as here in the States. But as you understand, and then these are some premises of osteopathy. Can you briefly just kind of explain, a little bit of background as far as what, classically trained, osteopaths, what they do, where they kind of come from? I mean, is there, just a small, quick story just to give everyone some context as far as, how it's
Sure.
different. You see a lot of guys in medical practices today with a DO, behind their name. They're operating a lot like a GP, more than, it's obviously different than thought process here. Can you explain that a little bit?
Sure. So the first osteopath was an American MD, Andrew Still. He was the one that was doing surgeries during the Civil War, and noticed he put his forceps during a back surgery. That story goes, he put his forceps on the dura mater when he was doing a lumbar surgery, and then he noticed that the scissors on a micro level were doing this oscillative rhythmic motion. And that's when he started looking further into the body and understood that there's an underlying movement, which is this whole PRM, this primary respiratory movement. So he was big on, the rule of the artery being absolute, which is what we were taught in chiropractic school, that all osteopaths believe. That was like old school osteopathic mentality. Now it's the more modernized version is structure dictates function, and function can also dictate the structure. Like those two are like constantly working together. Form and function, function and form. They're not inseparable, and they're not one way. So with that understanding of the body, plus the understanding of the fascia, he recognized that the fascia was linked to health, not only disease and health of that nature, but also orthopedic. That's kind of where the whole table got set. This is in the 1800s. Well, he started a school in Missouri. This is going to start to sound very familiar to chiropractors. He started a school in Missouri, and apparently part of his second group of students was Palmer. So the story goes that Palmer stayed in school until after maybe the second year of 6, and that's because they went through the year of manipulation and the nerves, which is, I explain to my patients, that's a portion of the original osteopathic principle or construct, because there's also craniosacral, and there's also the viscera, and there's also the fascial body, and all these other pieces. And that got truncated, and then that's how chiropractic was born. Directly an offspring of the original osteopath Andrew Still, which is
Wow.
super interesting. And then very quickly that fizzled out in the 50s or 60s. That's when those types of osteopath hands-on only were basically brought underneath the umbrella of the AMA. And that's why now you could have a surgeon that was a DO or an MD, and we wouldn't know the difference in this country. So then you had an underground up until like the 60s of a bunch of people, now they're older, that were like traditional osteopaths in this country. Then it spread to Europe and Canada. I don't know when. And they kept the original osteopathy program, which is why now for me, I had to go to Canada and my mentor was from France. That's the irony of the whole story.
Yeah.
Instead of it being here in this country. So that's how that whole system now a traditional osteopath, if you're not careful, is very similar in nature to the chiropractor, which we have a lot of outside influences from all different types of, whether it's movement or otherwise. And there's a group out there that is really staying true to the original tenets of you got to have fluid movement, you got to have space. Even if you're treating the viscera, you got to understand how the cranial sacral works into this whole puzzle, not just in head injury cases and, doing woo-woo treatments. Like you got to understand how it physically and structurally has an impact when you fall on your tailbone and 10 years later you have a headache. You got to understand the anatomy of the dura mater and how all of the pieces in between can lead to a consequence later. And that's all part of the complexity model of how we're put together and the understanding and things that we try to teach. It's a different way of perhaps looking at the body.
That's really helpful. To kind of wrap this up and Tim, I don't know if you have any other questions after Jason gets into this a little bit, but being a younger athlete, working with younger athletes, being part of the slightly silver haired crew now, look and talking to not only contemporary highest level athletes that you're working with, but even some of the younger kids that are in high school, college, and maybe earlier. You're thinking back to what you wish that you would have had access to then. What's at the top of the list as far as what could have changed, and thank God that you didn't, and thank God that a lot of us didn't, because of the work and the time and effort and energy and passion that you've put into learning about the human body and how it works and how to help others. But that what do you wish that you would have had access to that may have changed? That we may be talking to you because you're a 4-time Olympic gold medalist, rugby player or something. What are a few of those things that would have changed your career, and I guess some of the stuff that you impart to your younger athletes as far as the non-negotiables, the things that are just really, really paramount to the importance of being successful and performing at a high level.
I think this is the perfect audience, and I'm talking about you, John, and you, Tim, and that is, I think the biggest challenge is that it's not done in the weight room with weights. And I really, truly believe, and I know you guys work with a different type of athlete than I do, so it's not as much of a challenge, maybe in the surfing world, of guys wanting to deadlift and do all these things. But I'm like, the more and more I try to stay out of the strength and conditioning world, only because it just seems like another big puzzle and other things. But for sure, the gym makes you slower. You train slow, you get slow. And I think my career, and Tim, I don't like speaking for you, and John, I think we're always trying to undo some version of them being too tight or not fast enough or don't have enough access to their main drivers of their hip, their pelvis, or their back or something. I mean, sorry, strength and conditioning, but if you're not careful, I think it brings it crashes down on a lot of kids.
That was my, that's certainly my history. Playing college football in the 70s, man, it was all about iron and eating, those, and a little sleep in between. But it basically ruined me. Yeah, I got bigger, I got thicker. I was impressive to the coaches because they saw my weight gains and my strength gains, but my injuries went skyrocketing. And they didn't, back in that time, didn't have a biomechanical approach to it. And so for me, everything that you're saying and everything that we're doing now to create fluid exchange, to create a physiological pump, all those things are bearing such truth now. And so my patients get to benefit from that because I've lived the other end. So I'm highly committed to the very things that you're saying. And though we have different approaches, our goals are the same. And I appreciate what you're doing because it takes whatever I'm doing, the amalgam of things that I've put together and added to it and added to it in a very practical, promising way that allows me to get my athletes to places that I never got to go. And so at least I'm getting to see the benefits there. And certainly as an aging guy, I want to keep moving. I want to stay on my shortboard. That's, one of the things that I really appreciate. So everything we do in life, as it turns out, is fairly Machiavellian. We do a lot of stuff for ourselves. And so our knowledge here, and I think I can speak for John too, is really come from the downsides of life and being an injured athlete and being curious and wanting to know. And I'll leave this little statement with a little saying that our good buddy, Dr. Doug Anderson, uses often. He goes, I don't care what the truth is. I just want to know it. And I feel that camaraderie with you, and probably everybody that's listening on this podcast has a little bit of that in them as well. But I just want to thank you so much for expanding my mind and expanding my ability to think more critically in moments that really are important. So thank you.
Thank you, Tim. I mean, obviously, I mean, in my first CCSP, Tim was one of the instructors, and I've always looked up to you and what you've been doing and accomplishing. And I really appreciate you guys having me on here. It's really quite an honor.
We're humbled to have you.
Oh, thank you.
Yeah, we could do this all day. Real quick, based on what you just kind of talked about in the weight room and with strength and conditioning. I think there's some great trainers out there, right, who first and foremost focus on foundational movement, control, stability, balance. And so, and they're working at trying to get their athletes fast, and it's absorb force before you can create force, and then create force multiple times, all those premises. But to your point, a lot of the challenges that we see on a regular basis just come from people in a lot of different fields, not just strength and conditioning, that the ultimate issue is that you're just not strong enough.
Yep, totally.
And that you need to get stronger. And that, that mindset in lots of cases creates, a lot of challenges. I mean, we get it that, it's a quantifiable metric in a lot of cases where you're measured on how much can you bench, how much can you deadlift, how much can you squat. If we can move those numbers, we've been successful. But to your point, I think we hope in the future that there's a lot more thought process as it relates to trying to understand fundamental movement patterns, trying to make sure that they've got good quality of movement before you start loading them, and then progressing from there. And sometimes it's a slow process, but I think that you would probably take an athlete, who maybe can't lift as much, but moves really, really well and has great quality tissue. And it's something that Tim talks about on a regular basis with, the SPRT, therapy, soft tissue. It's you gotta create good quality tissue, before you can expect the brain to be able to activate and the nervous system to be able to connect, with those tissues. So.
Right. Absolutely. Yeah. I think the moving forward, I think the whole flywheel concept is a big one because that uses the fascial system and not so much the muscular system. It's all based on timing. That's a big part of the progression out of the pool and dry land is this whole flywheel thing to slow down and change direction. And it's predictable. You got to train predictable and to then maybe express that as unpredictable, which is what happens in sport, right? Most of the time, it's unpredictable change of direction is what hurts people.
Yeah, and not super linear.
Right. Exactly.
We train linear and then we wonder how we break,
Right.
because if you're an athlete, you're flowing. You're not in a box that has 90-degree angles.
Right. That's right.
Well, we're really looking forward to having you at the Movement Symposium, the SPRT Therapy Sports Movement Symposium in June 13th and 14th in Newport Beach, California. Jason's going to be there. Tim's going to be presenting on multiple topics. Dr. Eric Goodman from Foundation Training, Dr. Steve Capobianco from Rock Tape. We've got Dr. Mike Rentala and Dr. Drew Marcos from Dynamic Neuromuscular Stabilization, DNS, Dr. Skip George from Postural Restoration Institute, a number of others who are going to be speaking about, concepts and principles of just moving better. And so really look forward to having you, Jason. Thank you so much for everything that you do. And, all of the time and effort that you've spent over the years, just trying to even educate Tim and I,
Absolutely.
Not to mention all the athletes that you've helped along the way. You're one of the best, and we appreciate you. And thank you so much for your time.
Thank you very much. Appreciate it. Look forward to seeing you guys again in June.
Thanks again for joining us for today's SPRT Therapy Podcast. Stay tuned for new episodes in coming weeks. And please check us out on Instagram and online at sprttherapy.com for upcoming events and discounts on live educational courses. Until next time, have a great day and stand tall.
I lay on the beach, watch the sunset undress as I wind down.